Hello all and welcome to Webinar Wednesday. I am here with today's speaker, our very own Dr. Benjamin Dillon, a female urology specialist who practices at our main campus, Women's Center, and the Spring Medical and Diagnostic Center. Dr. Dillon graduated from the Mount Sinai School of Medicine, where he also completed his surgery internship and residency. Afterwards, he completed his fellowship at the University of Texas Southwestern Medical Center. And in his spare time, he enjoys running, cooking, photography, and spending time with his family. Now I will hand it over to Dr. Dillon, and this is just a reminder that you can send in your questions during the presentation, and he will address them at the end of the webinar. Dr. Dillon?
Thank you, and thank you everyone for registering and signing in today. So the objectives of our talk today will be to evaluate and discuss different types of urinary incontinence. We will briefly talk about the evaluation of patients who suffer from incontinence, and then briefly talking about some of the different treatment options for urinary incontinence. So let's just start with kind of the basics and nuts and bolts of urinary incontinence. And what is urinary incontinence? Well, pretty simply, it's the involuntary loss of urine. It can happen at any time, anywhere, any location. And there are three types of incontinence, which we'll talk about at greater length today. The first type is stress incontinence. The second type of incontinence we'll talk about is urge incontinence. And then there's something called mixed incontinence, which is a combination of both types of stress and urge incontinence. So urge incontinence, I'm sure this has happened to many of us in the past. Urge incontinence is when you have the sudden urge to go to the restroom, and there may not be a restroom nearby, or there's somebody using the restroom, you can't get your key in their front door, and you have an accidental loss of urine. We call it urine at a socially inappropriate time and location. Stress urinary incontinence is kind of what this picture is depicting, and this is the other type of predominant incontinence, which is incontinence with activity. It may happen when you cough, when you laugh, when you sneeze, when you jump on a trampoline with one of your children or grandchildren, even picking up groceries. And then there's mixed incontinence, which is the combination of both stress and urge incontinence. So a little bit about the pathophysiology. I know this is rather scientific for a lot of people, but just so you can understand what goes on physiologically with the bladder under conditions of incontinence. So this is the bladder right here, and this is the pubic bone, so this is the front, if you will. And when a woman coughs or bears down or picks something up, sometimes the bladder will descend, and this, which is the urethral sphincter, will open up and sometimes cause a loss of urine or a few drops of urine. And that's what this picture is depicting here, that as pressure increases here, this relaxes and results in the accidental loss of urine. And again, this is a stress incontinence picture. So how prevalent is incontinence? And you can see from this pie chart that it is very prevalent. In women under 60 years old, stress incontinence is the most predominant type of incontinence and occurs in about 55% of women. Mixed incontinence happens in 25%, and that leaves urge incontinence in 20%. As we shift and women get to the age of over 60, the kind of ratio between the different types of incontinence changes. Urge incontinence is present now in 35% of the patients, whereas stress incontinence is less predominant, occurs in 30%, and then mixed is 35%. So roughly there's a equal distribution of all types of incontinence once women hit the age of 60. And how important is incontinence? Well, it's very important. You can see from this chart here, it accounts for a lot of money to our healthcare dollars. It may be the cost of $4.2 billion that results in urinary tract infections. Skin care is a big one, $380 million. And then, home care, it accounts for $4.2 billion. And what that means is that a lot of times patients who suffer from incontinence, those loved ones who take care of them often find their continence is so bothersome and so debilitating that it forces them into an assisted care living, and that counts for roughly $4.2 billion a year. And then what about the impact of urinary incontinence on people's lives? And presumably because you are listening today, this has impacted your life in some way. And if you see, you are not alone, and that the impacts and how it changes and alters your quality of life can be very dramatic for a lot of people. So we'll start right in the top center, the physical. So obviously it limits what people can do from a physical standpoint. If you have stress incontinence, a lot of people will tend to avoid certain activities, be it exercise, riding a bike, playing tennis, jumping on a trampoline with a grandchild, so on and so forth. Occupational can also, we see an impact. It can force you to be not as productive in your work if you're running to the bathroom all the time or having loss of urine, having accidents. And then there's the psychological aspect. Obviously, when you feel as if your body is no longer what it used to and you can't control some of your daily functions that you've been used to doing from the time you were very young, this can have a very lasting and strong impact on your psyche. Then, as we talked about earlier, there's a domestic impact. Do you have to start to wear protective undergarments, be it pads, pull-up diapers, or pull-up underwear? And then, particularly here in Texas and during the warm days, can you no longer wear light-colored clothing? Do you avoid wearing tan or white pants because you're afraid if you leak, somebody will see you? And that is a big one I hear from a lot of my patients. And then obviously the social. Again, you avoid interactions, avoid going to the mall, might avoid going to movies or going dancing, all because of the fear of leaking. And then lastly, sexual. Women who leak perceive that they may smell of urine or are afraid to have intercourse because of an odor, or they may actually lose urine during the course of intercourse, and that's a big one, again, for some of my patients, what they tell me when they come into my office. So what else could incontinence be, and how do you know if you're suffering from incontinence, and how does your primary care doctor, and how do we assess patients when you come into our office? Well, we really look at signs and symptoms, and you can see from this chart right here, I don't have to go into it too much in detail, but stress incontinence and overactive bladder or urge incontinence are very different. Usually with overactive bladder or urge incontinence, you have an urge or sudden desire to urinate. That is often not present in stress incontinence. Again, with stress incontinence, you will leak during physical activity, not necessarily true in urge incontinence. And then the volume of urinary leakage varies with the two different types of incontinence. With overactive bladder or urge incontinence, it is a large volume of urine, where stress incontinence usually a smaller volume of urine. And then, again, running to the bathroom, often with urge incontinence, women have a hard time getting to the restroom before the loss of urine, and usually with stress incontinence, that's not a case, and you can reach the restroom before you have an accident. So those are kind of the symptom assessment and what questions you might be asked when you go to a primary care doctor or gynecologist or urologist. Now kind of moving on to a little more technical aspects, the evaluation of the incontinent patient. Again, like we talked about, we will talk and you'll be asked about the nature of your incontinence. How long has it been going on? How severe is it? Do you have any underlying medical or neurologic or urologic problems that may be contributing to your incontinence? You will have a thorough review of your medications, as there are certain medications which may contribute to your incontinence. And then we'll obviously evaluate the functional and mental status of the patient. If you bring a loved one in who is having incontinence, we try to see, well, they're incontinent because they physically just cannot make it to the restroom because mobility is an issue, or they have dementia or something cognitive that's going on. They're not aware that they're having accidents. That's what that bullet means. And then for female patients, we'll talk about a GYN history, how many times you've been pregnant, and how many of those pregnancies resulted in a birth. And then were these births related, were vaginal or cesarean section. And then we'll assess the risk factors. Obesity is a big risk factor for incontinence, both stress and urge, and then advancing age, as there is some data which shows that as you age, there can be a link between aging and incontinence. What kind of tests might be ordered for you when you go to a doctor for incontinence? Well, the first thing is we will do a urinalysis. This is a urine test that we look at, make sure there's no blood, there's no bacteria, there's no sugar in in your urine. We'll do some routine blood work, and then we may ask you to urinate into a machine which measures how much you urinate and how quickly. If you're wearing pads, we may ask you how many pads you're wearing, and sometimes we may even ask you to bring your pads in and weigh them. We may ask you to fill out a voiding diary. That is exactly what it sounds like. It's a very simple piece of paper that you record how much you go and how often. And then at times we may do what's called a cystoscopy, where we take a look inside your bladder to assess your bladder health. What are treatment options? There are a number, and we'll talk about these as we go on. So behavioral modification is one. And that includes timed voiding, meaning going based on the clock and not necessarily how you feel. Some pelvic exercises, medical therapy, which Botox is included, and then some surgical options, which are sacral electrical stimulation and some other surgery. So what is behavioral modification? Well, we talked about a lot of the risk factors for incontinence and what we can do. So the first one is weight reduction is a big one. If you're a smoker, stop smoking, not only for incontinence but for other overriding health issues. Avoid bladder irritants, which I'll talk about in the ensuing slides. And timed voiding, again, if it's because you can't make it in time and you feel that if you let your bladder get a little too full, you leak, well, we tell you never to let your bladder get a little too full and go to the bathroom, say, every 2 or 3 hours and see if that helps. And then fluid restriction, that's a big one. People tell me, I wake up all the time to urinate and I can't make it to the restroom. Well, if you're drinking 2 or 3 glasses of water right before you go to bed, that's a very easy fix. Then the bladder diet. You can see this is very long and involved and pretty much eliminates everything that you like to eat and anything that you can eat. So what I tell my patients is this one right here. Avoid caffeine, avoid alcohol, spicy foods, acidic foods and fruits, and nicotine. These are all bladder irritants and will exacerbate or worsen your urgency and urgent continence. Pelvic floor exercises. I'm sure you've all heard of them before and probably have tried them. These are the so-called Kegel exercises. You squeeze your pelvic muscles and try to strengthen and hold in the urine. This requires a very motivated patient. It works. It works mainly for stress incontinence, but the thing about it is it works, and then once you stop doing them, often you're back to baseline. We can send you to somebody who will assist you in learning to do Kegel exercise, and they may do something called biofeedback, which is a way to measure the muscle tone and strength of some of your vaginal muscles and pelvic muscles to help with your incontinence. Medical therapy is a big one. We have 8 medications on the market, oral medications that may help with your urgency and urgent continence. Again, most medical treatments are for urgent continence, not stress incontinence. The main side effects are dry mouth, dry eyes, and constipation. Occasionally patients will have blurred vision, some GI upset. Very rarely do we have urinary retention. That's kind of a historic thing. And then reasons not to have medication are urinary retention, narrow angle glaucoma, which is different from wide angle glaucoma, and ultimately if that's a concern, we'll just get in touch with your ophthalmologist. Problems emptying your stomach, history of intestinal obstructions, and myasthenia gravis. Now recently we've had a big change in our treatment algorithm or treatment options for overactive bladder. Most recently in January of this year, the FDA approved Botox. Now most people are used to hearing Botox for injection in their face and making their face look nice and smooth, and it kind of does the same thing in the bladder. It's a paralytic agent, and what it does, it helps reduce some of those urges and uncontrolled squeezing of the bladder. It works unbelievably well. It can often be done in the office. It does have to be re-injected every 6 to 9 months, but often patients who can't take medication or don't want to take medication are very thrilled and pleased with this treatment option. There's something called Pessary devices. Now we're kind of moving more towards the stress urinary incontinence treatment options. These are mainly used for prolapse, which is, I guess, a different topic in and of itself, but there are some Pessary devices which do have a urethral component. This isn't my personal favorite for treatment of stress urinary incontinence, but again, an option which is out there for my patients. Then there are a whole host of surgical options, and I'll kind of blitz through these because these are often discussion about these and the pros and cons are very personal and geared towards a real personal discussion of a personal incontinence and not as much an overriding treatment of stress urinary incontinence. There's something called a bulking agent, which can be done in the office. This quote-unquote plumps up your urethra and may increase the resistance or make it more difficult for you to leak. The retropubic suspension is somewhat of a historic surgery. This was done years ago. This is somewhat fallen out of favor by urologists and gynecologists, but nevertheless, under a certain condition, it is the right option. Same thing with bladder neck suspension, somewhat historic, but still a good option for the right patient. There are various different types of slings that we can use for incontinence. There's something called Pubovaginal Sling, which is made from your own tissue, and then minimally invasive slings, of which there are two types. There's a sling for men, for any male patients tuning in for incontinence, and then there's something called an artificial urinary sphincter. All these, again, are surgical options. Bulking agents, as I've talked about, this can be done in the office. It can plump up the urethra, so to speak, increases the outlet resistance, and makes it harder to have stress incontinence. Efficacy is anywhere from 50 to 60%, but a lot of patients are very happy, and at times patients need to be retreated. Here's a picture before and after. This is before of what the urethra would look like before incontinence, before bulking agent, and this is after. You can see it's nice and closed and would probably make it harder for that patient to leak. Pubovaginal sling, again, surgical option. These are pictures detailing the procedure. Again, if this is something that comes to it, you will discuss this with your surgeon, but this is an older surgical option, a little more invasive compared to some of our newer less invasive surgical options, which are midurethral slings. There's a large worldwide experience, similar success rates to some of the older surgeries. There are various risks, intrinsic risks to any surgery, particularly with slings, which should be discussed in person with your surgeon. I don't think that this is necessarily the proper format to discuss that, as we could give a whole webinar on just slings in and of itself. But these often patients are extremely satisfied, usually anywhere between 93 and 98% of patients are extremely satisfied and would do this procedure again or recommend it to their friends or family. So that's really all I have right now. I'd be happy to answer any questions from all of you guys. So the first question is incontinence more prevalent after menopause? Well, certainly I think if you look at the data, incontinence kind of occurs throughout a spectrum of life, but certain types of incontinence, particularly stress incontinence, there is an increased incidence postmenopausally in women. Again, that a lot of people think that and a lot of data shows that may be secondary to hormonal status, not having a uterus, if a uterus has been removed, but certainly incontinence is more prevalent after menopause. As far as the type of incontinence, again, as that one slide showed, usually after the age of 60, there's kind of a 1/3 split among stress incontinence, urge incontinence, and mixed incontinence. Second question, does antidepressant medication increase the likelihood of incontinence? A good question, and not really clear-cut that it increases the likelihood of incontinence. In fact, in Europe, an antidepressant is used to treat stress incontinence. It was on the market here in the United States, but has been removed because of the side effects of the antidepressant, particularly increase of risk in suicidal ideations, but it should not inherently increase your risk of incontinence. Third question, is being overweight or obese a contributing factor toward incontinence? And that's a resounding yes. Numerous studies have shown that the best treatment option for a patient who is overweight or obese, for that matter, is weight reduction. And there are various anatomical and physiological reasons, which I'd be happy to discuss with you in person, but certainly is not again, this is not a proper format, but that is often the first-line agent that we as physicians can counsel patients on, and patients you can start at home if you are overweight. And I understand certainly it's difficult for a lot of patients to lose weight, particularly as you're postmenopausal, but that is a major way that you can reduce your incontinence. Is diabetes a risk factor for incontinence? It can be. Again, depends on how controlled diabetes is, how advanced it is. This is, again, a kind of a personal issue, and we look at very, it's multifactorial. So we looked at multiple things going on with a patient to see if, yes, it is increases one's risk or not. But as a blanket statement, I can't say for sure whether diabetes increases the risk of incontinence. So there's another question is, why are women at risk to urinary incontinence after childbirth? Being at risk for incontinence after childbirth is kind of, that should fall under the kind of headline of pelvic floor disorders. Urinary incontinence is the second most type of pelvic floor disorder, and as women carry a baby in their uterus and the pressure is put on the pelvic floor, it weakens some of your pelvic floor muscles. So again, without getting too much into detail as far as the pathophysiology behind stress incontinence or urge incontinence, if you weaken the pelvic floor and put a lot of stress on the pelvic floor for 9 months, or 18 months, 27 months, however long or how many children you have and carry, yes, it can certainly increase, because that pelvic floor weakness and structures are, I don't want to say damaged, but a lot of stress and strain is put on them. Does smoking increase the risk of incontinence? As I covered earlier on the talk, nicotine is certainly an increased risk factor for urge incontinence. So yes, smoking does increase your risk of incontinence. A good question right here, isn't urinary incontinence a natural result of the aging process? And my answer to that is no. Is it natural? No. But does it happen as we age? Yes. And it's, I wouldn't say it's normal. It happens a lot and we see it a lot, but it's not normal, and patients who suffer from incontinence as they age should know that there are options. And that's part of the driving reason for doing this webinar, is that it's not normal, but it's common. Just thumbing through some of these questions that I haven't covered yet. I think here's a very good question. At what point should a physician be consulted? Is it sooner or better to wait until it's a problem? Well, and that's a personal problem, and what I tell people who ask me casually when they should see a doctor. And I think it really depends on you as a patient, you as a person. When it bothers you is when you should see a doctor. If you don't mind having a few episodes of leakage when you play tennis or when you cough or when you jump, do whatever, and it doesn't bother you, that's great. But I have some patients who leak very seldomly and it bothers them tremendously, and that's when they come see a doctor. So whenever it bothers you and you're bothered by it socially, physically, emotionally, is when you should seek treatment. Some of the more personal questions I think are best kept to consult with your primary care doctor, or certainly contact one of us. So this is not really the format to discuss personal questions. So I think that is about it. I think we've pretty much addressed most of the overriding broad questions. Again, thank you all for turning in. I'll turn it back over to Kelly. Thank you.
Well, this concludes our webinar Wednesday. We hope that it was very informative for you. Please join us next month for Dr. Tabor's webinar as he shares his expertise on how to jumpstart a workout program. Don't forget to like us on Facebook, tweet us on Twitter, Watch us on YouTube and pin us on Pinterest. Happy Wednesday and have a great day.